Imagine like a fire just burning inside your body for years.
Oh, wow. Okay.
Yeah, it's a slow, smoldering burn that, it melts the wiring, warps the floorboards, but the smoke alarms literally never go
Yeah,
off.
complete silence.
Exactly. You feel completely fine. You just go about your life totally unaware of the structural damage happening inside until one day, a totally normal physical movement triggers absolute agony.
And by then, the fire is long gone.
Right. The fire is out, but the wreckage remains. Welcome to the deep dive.
Oh,
Today, our mission is to decode a really specific, almost unbelievable medical mystery.
it's a fascinating one, too.
It really is. We're looking into whether a chronic, entirely subclinical pelvic peritonitis following a chlamydial infection can cause these fine microadhesions that make deep thrusting during intimacy intensely painful.
Yeah, it sounds like this incredibly cruel biological domino effect. You're essentially looking at a scenario where a localized, invisible event sets off this massive systemic, structural, and neurological crisis.
It completely transforms the biomechanics of the human pelvis.
It does. It totally does.
And to figure out how this actually happens, we are pulling from a massive stack of sources for you today. We've got pediatric and adolescent medicine reviews, official OB/GYN clinical guidelines, including the British Association for Sexual Health and HIV.
Great data in there.
Oh, definitely. Plus pathology reports and some really dense surgical analyses on endometriosis and chronic pelvic pain. We basically need to connect the microbiology of that initial infection to the macroscopic anatomy of the pelvis.
Right, and finally to the neurology of chronic pain.
Exactly. Okay, let's unpack this, because setting the stage is crucial here.
Yeah, and the only way to really understand this cascade is to start at the molecular level, right? With the pathogen itself.
The silent invader.
Exactly. Chlamydia trachomatis. It is an obligate intracellular pathogen, which means, it cannot synthesize its own amino acids or completely generate its own ATP.
It's totally reliant on the host.
Right. It is entirely dependent on breaking into a host cell just to survive. And it is shockingly good at flying under the radar.
That's the scariest part for the listener, honestly. You could have this for years.
You really could. Up to 80% of chlamydial infections in women are subclinical, meaning they present with literally zero symptoms.
Zero. That asymptomatic nature is really the crux of this entire mystery. A patient could harbor this pathogen in the cervical epithelium for years and years.
Yeah, and the mechanism of how it survives inside the host cell without being detected is, what's fascinating here is that the bacteria actually has a biphasic life cycle.
It's like a stealth operative breaking into a factory.
I love that analogy.
Yeah.
It approaches the host cell in this extracellular form called the elementary body, or EB.
And that form is inactive, right?
Metabolically inactive, yeah. But it's encased in this incredibly tough cross-linked protein shell. It's essentially an armored transport vehicle.
Right, so it rolls up to the factory walls in a tank.
Basically, yeah. It attaches to the host cell membrane and actually induces the cell to engulf it. But once inside, the elementary body doesn't get destroyed in a lysosome like a normal engulfed pathogen would.
Because it actively fights back.
It modifies the compartment it's trapped in, creating what we call an inclusion vacuole. Inside this little protective bubble, it sheds its armor and transforms into the reticulate body.
The RB.
Right, which is the metabolically active replicating form.
So it sets up a rogue factory inside the host cell. And because it lacks the genetic machinery to produce enough of its own ATP, it acts as an energy parasite, right?
Oh, entirely. It inserts transport proteins into the membrane of its protective vacuole to just siphon ATP directly from the host cell cytoplasm.
It is literally stealing the cellular power grid to fuel its own replication.
It is. And the evolutionary biology at play here is remarkable. Chlamydia trachomatis has undergone reductive evolution.
Meaning it tossed out what it didn't need.
Exactly. It threw away the genes required for independent survival because, stealing from the host is just more efficient, provided it can keep the host cell alive long enough to replicate, of course.
Which brings us to how it manipulates apoptosis. Because normally, a cell infected by an intracellular parasite will just hit the self-destruct button.
Right, to halt the infection. But the chlamydia secretes these effector proteins that actively degrade the host cell's pro-apoptotic factors.
So it holds the cell hostage.
Yes. It forces the cell to stay alive and just consumes all its resources until the vacuole is packed with newly formed elementary bodies.
At which point, the host cell finally just ruptures, releasing a whole new wave of those armored elementary bodies to infect the neighboring tissue.
And if the cycle begins in the cervix and isn't interrupted by antibiotics,
Because, again, the patient has no symptoms and no reason to seek testing.
exactly,
Right.
then it just slowly ascends. The bacteria migrate up through the cervical canal into the endometrial cavity and eventually out into the fallopian tubes.
Causing silent esophagitis and subclinical pelvic inflammatory disease.
Yeah. Now, the pathogen might be hiding inside the cells, but the immune system isn't, like, completely oblivious to this happening.
Right. It notices the wreckage.
When those host cells rupture and release the new bacteria, they also spill cellular debris and chlamydial antigens into the extracellular space.
Mm-hmm.
This debris is detected by resident immune cells, like macrophages, which sound the alarm.
But it's a really muted alarm, isn't it?
It is. The immune system detects a threat. But because the bacteria spend most of their life cycle hiding inside the host's own cells, the immune response gets incredibly frustrated.
So the body resorts to basically flooding the area with inflammatory cytokines, particularly tumor necrosis, factor alpha, and all those various interleukins.
Right. The local tissue is subjected to this constant barrage of reactive oxygen species and proteases secreted by neutrophils that are just desperately trying to clear the infection.
It's the biological equivalent of like carpet bombing the entire neighborhood because you can't locate the sniper hiding inside one of the houses.
That is a perfect way to describe it. And this chronic, low-grade inflammation of the pelvic cavity is pelvic peritonitis.
So how does a microscopic bacteria lead to actual structural changes in the pelvis? Because the collateral damage from this immune response is severe.
It's devastating. The delicate, ciliated epithelial cells that line the fallopian tubes, they just get destroyed by the persistent inflammation. We see localized tissue edema, mucosal necrosis, and just a constant state of cellular injury.
And to repair this continuous damage, the immune system upregulates fibrogenic factors, right? Like the primary driver mentioned in our pathology sources is transforming growth factor beta.
Yep, TGF-beta. This cytokine is essentially the master regulator of tissue repair. It recruits fibroblasts to the site of injury and transforms them into myofibroblasts.
Which are the cells that lay down those dense networks of collagen and extracellular matrix, basically scar tissue.
Right.
But wait, here is where I really have to question the evolutionary logic of this response. The body is using scar tissue to wall off the infection and repair necrotic tissue. But in the enclosed, dynamic space of the female pelvis, laying down sticky, contractile collagen bands seems like a catastrophic design flaw.
It does seem counterintuitive.
Right. It literally glues the reproductive organs together, which, from a Darwinian perspective, severely compromises the organism's ability to reproduce. Why would the body's defense mechanism be so locally destructive?
Well, it's really a matter of prioritizing systemic survival over local function. The immune system's primary goal in peritonitis is containment.
Keep the fire in one room.
Exactly. If the infection were to spread freely through the peritoneal cavity, it could lead to systemic sepsis, which is fatal. So the body is totally willing to sacrifice the mechanical mobility of the pelvic organs, and by extension fertility, to build a fibrous wall that keeps the pathogen localized.
Wow. And the extreme lengths the body goes to for this containment are really evident in Fitzhugh-Curtis syndrome, which is highlighted in a bunch of the pathology reports.
Oh yeah, that is a wild complication.
Right. The localized pelvic inflammation can track all the way up the right pericolic gutter and actually reach the liver capsule. And then the body forms these intense fibrous adhesions between the liver and the anterior abdominal wall.
Surgeons describe them as looking exactly like violin strings just spanning across the abdominal cavity.
Violin strings on the liver. It proves how far-reaching this subclinical inflammation can be. And if the inflammatory cascade is aggressive enough to form those violin string adhesions all the way up on the liver, the structural chaos happening down in the confined space of the true pelvis is just immense.
Immense. And you have to remember, a healthy pelvis relies on mobility. The uterus, the ovaries, fallopian tubes, bowel, bladder, they're all coated in this slippery layer of peritoneum.
They are designed to glide over one another dynamically.
Exactly. When the bladder fills, the uterus naturally tilts out of the way. When the bowel contracts, the surrounding tissues yield.
But the heavy deposition of collagen driven by that TGF-beta completely destroys that dynamic environment. The sticky fibrous bands mature into really dense adhesions.
You do. The uterus becomes literally adhered to the rectum. The ovaries get tethered to the broad ligament, or the pelvic sidewall.
And this is the condition gynecologic surgeons refer to as a frozen pelvis.
Right. The organs are locked into a rigid block of scar tissue.
And this structural lockdown brings us directly to the physical mechanics of the pain, the deep dyspareunia. When we look at chronic pelvic pain, we have to isolate exactly what tissue is being stressed.
Right, because this isn't superficial pain at the vaginal entrance, which is typically driven by, acute infections, dermatosis, or atrophic changes.
We are analyzing pain localized deep within the pelvis, triggered specifically by physical penetration.
And the anatomical geometry is just crucial here. During deep thrusting, the physical force is directed at the vaginal apex, the fornices. And just behind the posterior vaginal fornix is the pouch of Douglas.
Which is that anatomical cul-de-sac between the posterior wall of the uterus and the anterior wall of the rectum.
Right. Now, in a state of normal pelvic biomechanics, the uterus and the surrounding peritoneal structures are freely mobile. So when physical force is applied to the vaginal vault, the uterus just yields.
It bounces.
Yeah, it is elevated upward and anteriorly, absorbing the kinetic energy without excessively stretching the surrounding connective tissue.
But in our scenario, the patient has a frozen pelvis, or at least, significant adhesive disease in the pouch of Douglas, courtesy of that silent chlamydial fire.
Exactly.
The uterus and the rectum are anchored together. They cannot yield. So the kinetic energy of deep thrusting hits the vaginal vault and immediately translates into the severe traction force on those lockdown organs.
And patients in the clinical data, they consistently describe this as a sharp, sickening sensation of something being hit.
Like hitting a wall.
Right, because the force is forcefully stretching the tethered tissues.
Yeah.
And these adhesions are frequently vascularized and actually contain entrapped nerve endings.
Ouch.
Furthermore, the mechanical traction pulls aggressively on the peritoneum itself, which is a highly innervated membrane. The structural limitation is directly triggering a massive volley of pain signals.
And that mechanical explanation makes perfect sense for dense, thick adhesions. But the surgical guidelines from the RCOG and Sager introduce this massive paradox that we really need to dissect.
Yes, this is where it gets really complicated.
Because our mission question specifically focused on micro-adhesions, those really fine, filmy strands of scar tissue. We know from clinical data that when a surgeon goes in laparoscopically and lilises or cuts dense adhesions, patients often experience significant relief from deep pain.
They do. But the paradox emerges when surgeons perform adhesiolysis on fine, filmy adhesions. Yeah. The high-quality, randomized controlled trials demonstrate absolutely no difference in pain outcomes between women who had their fine adhesions surgically divided and those who only had a diagnostic laparoscopy where the microadhesions were left completely untouched.
So, if physically cutting the fine adhesions doesn't stop the pain, does that mean the microadhesions are merely innocent bystanders? Are they not the actual cause?
That's a great question.
I mean, a filmy microadhesion looks like a spider web. Mechanically, it does not possess the tensile strength to anchor the uterus to the rectum and resist the kinetic force of deep thrusting, right? It shouldn't be capable of causing that acute stretching pain.
Mechanically, no, it shouldn't. But this is where we have to transition from structural anatomy to neurobiology.
The nervous system connection.
Exactly. The microadhesion isn't the primary source of the pain. It is a biomarker of the toxic environment the local nervous system has been marinating in for years.
The chlamydia aftermath.
Right. The chronic subclinical pelvic peritonitis didn't just lay down collagen. It bathed the pelvic nerve terminals in a continuous soup of inflammatory mediators, prostaglandins, cytokines, and nerve growth factor.
And this persistent chemical irritation fundamentally alters the physiology of the peripheral nerves, which the sources call visceral hypersensitivity.
Yes. The constant exposure to inflammatory markers causes the nociceptors, the pain-sensing nerve endings in the pelvic tissue, to physically change.
How so?
Well, they upregulate their ion channels. Their activation threshold literally plummets.
It's the neurological equivalent of a severe sunburn, isn't it?
That is a great way to think about it.
Like if you have healthy skin, someone resting their hand on your shoulder just feels like gentle pressure. The sensory nerves relay a neutral, tactile signal, but if you have a blistering sunburn, that exact same physical pressure triggers excruciating pain.
Right, the mechanical force applied to the tissue didn't change at all, but the sensitivity of the alarm system is completely warped.
So visceral hypersensitivity means the peritoneal lining and the pelvic organs are just neurologically sunburned.
Yes, but the adaptation doesn't stop at the peripheral nerves.
Well,
The constant bombardment of pain signals travels up to the dorsal horn of the spinal cord, leading to what we call central sensitization. The central nervous system itself becomes hyperexcitable.
so it begins to amplify the incoming signals.
Precisely. Sensations that should be perfectly normal, the distension of the bladder, the movement of the bowel, or the normal tissue stretch during intimacy, are catastrophized by the spinal cord and interpreted by the brain as severe tissue damage.
Wow. So the microadhesion is sitting in an environment where the entire nervous system is operating on a hair trigger. The physical force of deep thrusting might only cause a microscopic stretch of that filmy adhesion, but the hypersensitized nerves interpret that tiny stretch as a massive trauma.
Exactly. And the neuromuscular system then adds another layer of complication on top of that.
Of course it does.
In response to this chronic amplified pelvic pain, the pelvic floor muscles engage in a guarding response.
Right, the levator ani muscles.
Yes, they enter a state of chronic tension, leading to pelvic floor hypertonicity. The muscles are basically constantly spasming in an attempt to splint the painful area and protect the pelvis from further perceived injury.
So this means the mechanical force of intercourse isn't just hitting sensitized tethered tissue, it's hitting a rigid wall of spasming muscle.
Exactly.
The biological reality of this condition shifts from a purely structural problem, which, a surgeon could theoretically fix by cutting a band of scar tissue, to a massively complex neuromuscular disease. The nerves are misfiring, the muscles are locked in spasm, and the physical architecture is altered.
This is exactly why cutting a fine microadhesion achieves nothing. You are snipping a spiderweb in a house that is still on fire neurologically.
That is so bleak, but makes perfect sense.
The treatment paradigm has to shift entirely, moving away from surgery toward nerve modulators, targeted pelvic floor physical therapy to downregulate the muscle spasms, and cognitive behavioral approaches to address the central nervous system's amplification of the pain signals.
Right. So pulling all of these threads together, it just paints a staggering picture of how deeply interconnected our biological systems really are.
It really does.
For you listening, just think about this journey. A patient contracts an obligate intracellular bacteria that acts as a stealth energy parasite. It hacks the host cell's apoptosis programming to survive undetected. This silent invasion triggers a frustrated chronic immune response.
And that resulting pelvic peritonitis damages the tissue, prompting TGF-beta to initiate a fibrogenic repair process.
That repair process lays down adhesions in the pouch of Douglas, mechanically altering the mobility of the pelvic organs. And simultaneously, the years of inflammatory mediators lower the threshold of the peripheral nociceptors, inducing that visceral hypersensitivity and central sensitization. Ultimately, when the mechanical force of deep thrusting is applied, it stretches organs that are structurally tethered and neurologically sunburned, all while colliding with pelvic floor muscles that are locked in a defensive spasm.
The result is debilitating deep dyspareunia.
The initial infection may have been completely subclinical, totally silent, but the long-term biomechanical and neurological fallout is just devastating.
It is. And, the medical literature presents one final concept regarding the psychology of chronic pelvic pain that complicates this picture even further.
Oh.
Yeah. It explores what happens when the biological drivers of the pain are successfully treated, but the pain itself persists.
Wait, really? Walk us through that scenario.
Okay, so suppose the patient receives the correct antibiotics. The chlamydia is completely eradicated, the inflammatory cytokine production ceases, they undergo extensive pelvic floor therapy, and the hypertonicity resolves.
So the structural and inflammatory fires are completely extinguished.
Exactly. The purely mechanical and inflammatory sources of pain are gone, but the neuroplasticity of the brain remains.
Oh, I see where this is going.
After years of experiencing intense agony during deep penetration, the central nervous system has learned a potent biological association. The anticipation of intercourse itself becomes a trigger.
The brain predicts the trauma before the physical stimulus even occurs.
Yes. The psychological distress and the fear of the anticipated pain trigger an immediate involuntary autonomic response.
So the body reacts before anything even happens.
Right. The sympathetic nervous system engages, which drastically decreases vaginal lubrication, dramatically increasing mechanical friction.
Wow.
And simultaneously, the fear triggers an involuntary reflex spasm of the pelvic floor muscles, a condition diagnosed as vaginismus.
So the brain's attempt to protect the body from a remembered trauma actively synthesizes the exact physical conditions required to create a brand new source of pain.
Exactly.
The original chlamydial infection is gone, the peritonitis is cured, but the expectation of pain becomes a self-fulfilling prophecy. The line separating a historical structural injury from a present-day psychological expectation just completely dissolves.
It does. And it demands a deeply holistic approach to patient care. When the nervous system has been fundamentally rewired by chronic inflammation and pain, treating the pathogen is only the first step.
Unwinding those learned physiological defense mechanisms has to take immense time and multidisciplinary intervention.
It absolutely does.
It is a profound reminder that we are not simple machines. You can't always just look at a scan, point to a broken part, and replace it. When a silent infection smolders in the dark, it doesn't just leave scars behind, it changes the way the body interprets its own existence.
Brilliantly said.
The landscape of chronic pelvic pain is infinitely complex, and navigating it requires looking far beyond the obvious structural damage. Definitely something to think about the next time you assume a silent infection means a harmless one. Thanks for joining us on this deep dive.